My name is Mehmet Asım Bilen. I am a geomedical oncologist at Winship Cancer Institute of Emory University, and I'm the director of Genitourinary Medical Oncology program, and I'm the associate medical director for the phase 1 program here at Winship. The renal cell carcinoma is the most common type of kidney cancer, and roughly around 85% of the cancer in the kidney is renal cell carcinoma. But renal cell carcinoma is a very heterogeneous cancer. There is different subtypes, more than a dozen. But when we see a patient with kidney cancer, we ask the question whether this is clear cell or non-clear cell kidney cancer, because this is the first split. The clear cell renal cell carcinoma is about 75% of the individual, which is the most common subtype of kidney cancer. The commonly associated mutation is VHL, and most of the medications and clinical trials are specifically looking patients with clear cell renal cell carcinoma. But when we look at the non-clear cell renal cell carcinoma, there is a number of different subtypes. The most common subtype is papillary, which is about 10 to 15%. And papillary kidney cancer also split into two different types, papillary type 1 and papillary type 2. Papillary type 1 is commonly associated with c-Met, like a mutation. And papillary type 2 is associated with FH, like a mutation. And the other subtype is chromophobe. Approximately around 5% of the cases have chromophobe. And the common mutation we see in chromophobe renal cell carcinoma is BHT. Another rare subtype is collecting duct, which is around 1%. And this is a very aggressive subtype, which is arising from the collecting system of kidney. And this is the only subtype we tend to treat initially like a bladder cancer or upper tract urothelial cancer with platinum-based chemotherapy. But those patients, unfortunately, have very aggressive and poor outcome. Another important subtype is renal medullary carcinoma. Again, this is roughly around 1% of the cases, and this is very, very aggressive. Tend to be seen in African American population with sickle cell trait. Because of this reason, when I work with my fellow, this is the first question I ask. If someone came with renal mass, like a young, African American descent, history of sickle cell trait, we always think about renal medullary carcinoma. Again, this is a very aggressive subtype, very rapidly become metastatic disease, and we need to develop better therapy options for those patient population. And this is also another subtype we tend to use chemotherapy, such as carboplatin, taxane, or gemcitabine, doxorubicin, but is still very a poor outcome. And the last subtype is called unclassified. Unfortunately, not always our pathology classify under the microscope. If a case doesn't belong any of those different subtypes we listed earlier, then unclassified renal cell carcinoma is another entity we see. This is about 2 to 3% of the tumor. And again, is very, very aggressive a biology. Because of this reason, we are dealing with a cancer that have different biological and molecular backgrounds. Because of this reason, response to traditional therapies such as angiogenic inhibitors or immunotherapeutic agents, the response to those agents are really different from subtype to subtype. And as I mentioned earlier, the clear cell is the most common version. Because of this reason, all the drugs tested on clinical trial and led FDA approval enrich for patients with clear cell RCC Because of this reason, we cannot see the same response in a non-clear cell population. We desperately need like a better and effective therapy options, like for especially patients with non-clear cell RCC. Because of this reason, clinical trial play an important role, and we encourage everyone to consider clinical trial enrollment for patients with kidney cancer, particularly non-clear cell renal cell carcinoma.